Uh, we have the next speaker, Dr. Lahane, and he'll be speaking SICS in traumatic eye. Very well. So sometimes you have to.
Okay. Thank you, Sanjay Natarajan. Uh, Now this is we can operate the case with the SICS when there is a, अरे आगे नहीं जाता है. Okay, now it is going. Now see, the ocular trauma related to the visual morbidity is almost 20% in India. And sequelae of the trauma could vary from the hypema to the glaucoma to the corneal tear to the cataract. So I think you have seen all these types of injuries and how to manage. The traumatic cataract have associated with the ocular conditions such as synechiae, you can see zonular weaknesses, corneal opacities, retinal holes. And this management needs towards the treatment of all the associated ailments. It means you require a sometime team to operate such cases if there is opacity. Now see, this is the patient, 28 years old male, and see the suturing is done there, and after suturing the patient cataract, you can see there is a cataract seen with a traumatic cataract, and this traumatic cataract is managed by the SICS. Now the other question will be asked to me, that is it possible to manage by femto, by phaco? Yes, you can definitely manage this cataract with any type of the things that is in your hand and where you are well conversant. Now this is what I am doing is the traumatic cataract, and then the after doing this rexis, this rexis, can you see this? Whenever I am trying to do the rexis, the nucleus is rotating and this nucleus is brought in the anterior chamber, and then this is just delivered by the SICS. And then the aspiration, here I always use the AC maintainer, and by the AC maintainer I am removing the epinucleus and also the cortex. This is removed, and you can see the what opacity remained is a trauma there, and now you can see some glow, and then implanting the lens. So when you are doing phaco in such cases, you may not see properly because of the corneal opacity. But yes, few people, those who are expert, they can go for the such type of thing. Another thing is iridodialysis. So this is the common, that now see, this is a, you can see in between the two lenses are seen, because lens is also subluxated down, and you can see two lenses, but that is one lens only. So that is for the Mohan Rajan. OPL case. And then now this time also he might have brought some things. Now see, I am trying to do the rexis, and you will see the fibrosis of the anterior capsule, and then this is the lens. Can you see? It's very, you can say, huge lens like a nuclear cataract, and this lens is brought out. Now when the lens is brought out, you can see the iris repair can be done, and this I am doing the iris repair for, and then that I will complete it. Other thing is the subluxated. Now see the place, this incision is very important whenever you are dealing with the subluxated, because I am dealing with SICS. Placed away from the area of the zonular weaknesses, incision in the gradient opposite to the zone of the maximum zonular weaknesses. Surgeon should not jeopardize his surgical ability by operating in a meridian where he is uncomfortable. Sclerocorneal incision allows ease of the conversion to the SICS. It means every time it is not possible that you can do phaco. But if you want to do phaco, you can go for the surgical, this scleral incision and do phaco. If not possible, just convert. Corneal conversion of the corneal is always difficult and you get more astigmatism. A generous amount of the this retentive viscoelastic or chondroitin sulfate depressive over the area of zonular dialysis will help you for the surgery. Now Rexis here started in the area away from the dialysis. Where the dialysis is not there, you can start the Rexis. The use of the trypan blue dye. The capsular Rexis should be centered on the crystalline lens, not on the pupil or on the corneal apex. The femtosecond laser, just now you have seen the Mohan operating with femtosecond is always better. But the people in India, they are not having femtosecond laser. In each city there may be 3, 4 big cities, metro. And other places no femto. So we'll have to go with our whatever we are doing by our hands. Okay. Now see, this you can see the after the staining, what I have started the Rexis in the area where the zonules are intact. Otherwise, in that area where the zonules are not intact, Rexis is difficult. So here I am doing the Rexis, and you can see the Rexis is completed as it has started from the area where there is a strong support to cut the capsule. And once that is done, then you can go ahead for this. Now the capsular tensor ring is inserted using the forceps or specially designed injector. A fishtail technique you can use there. Now when, see, insertion before nucleus delivery is placed before the phacoemulsification is a safety suture and is looped through the leading eyelet, or insertion after the nucleus delivery, capsular bag should be stabilized till the nucleus is managed and CTR is inserted with the simple forceps and simple technique. Now this is the capsular axis. Okay. The contraindications of the CTR or MCTR, the complete continuous capsular axis is not attained. It means your axis is not there. You should not put the CTR. Posterior capsular tear, that is also a contraindication. Extensive generalized zonular weakness, if it is all over, you should not. And MCTR is not to be used in the patient with scleral disorders. In other places you can use it. The once, I think one video has not run, okay. Be prepared for the surprises, better to equipped with the vitrectomy and CTR. Do prime consent. See, whenever you are taking consent in such situations, when patient is young and father and mother are more anxious, so that consent is very, very important. And if that consent is proper, then there is no problem. I think this video is not running. We will see if it runs. Okay, now see this. This is the, again you can see what I am doing is a Rexis. And here again, whenever I am doing the Rexis, I am starting in the area where the zonules are strong. And in that area where the zonules are not strong, I am not going. And you will see what I am doing is on the lens, center of the lens, and not in the center of the pupil. And see now, this is the CTR. Can you see this? I am putting before the nucleus delivery. So this is the CTR, because you have seen the subluxation is much more, and so it is not possible to remove the nucleus without stabilizing it. So I am stabilizing by the CTR, and the CTR is in just, and then after doing that I can see this IOL is planted here. I am just putting the IOL, and this is a rigid IOL. So because this is also again support that area where there is a zonular dehiscence is there, and you will see the lens is implanted. So this, I think the video, so the take home message is consent. So always remember, consent is very important. And the child is crying, the father and mother is crying, and that time we will not take proper consent, and then patient will be unhappy. So whenever the trauma case comes to you, always better to tell them properly, counsel their one of that person, that is father and mother, is more aggressive, and you will have to see who is more aggressive and tell them. And another thing you must do is take the signature of both, not one signature. Always remember, when the patient age is less than 18, signature of mother, if she is there that time, and when father comes later on, his signature. Both signatures will help you when you are doing the such type of traumatic cases. Thank you very much.
Thank you, sir. Thank you very much. So just a question. You do both FACO as well as SICS. So what would be your preferred choice? And we have seen Dr. Mohan Rajan showing us.
My preferred choice goes according to the cataract.
Right.
If I am able to do FACO, my first choice is FACO.
Your first choice.
But if I am not able to do FACO, I never give any strain to my heart vessels.
Yeah, that's also
I
important.
always feel ki it is my vessels are more important than the
Than the
patient.
cataract.
And so I always see ki my vessels are
Are
good.
intact and
Yes,
open.
intact
And open.
contracting and open.
Yes.
Yes.
ACM is your ACM, sir. Anti-simple maintenance.
Yes.
It's beautiful it is. It's going
Yeah.
through it's making a tunnel into the cornea and strengthening fitting.
Yes. So because it has some serrations, so you can fit it inside. The upper sum is making that serrations are there. Okay.
Thank you, sir.